Not really. Aspirin treatment is quite universal.
Okay.
Means there is no two way about it. Most everyone will be on aspirin. Okay, it's just the IVIG part depends. Some the fever settle. As I said earlier, it's a self-limiting disease. Some of the fever, even day 4, day 5, they settle on its own. But they will still have all the Kawasaki features, full Kawasaki features, fever plus all the 4 or 5 criteria. But somehow the fever settle, then the CRP, all the inflammatory markers, not that very high, then they may not need IVIG lah. So the IVIG basically just to reduce the inflammation. So if that kind of scenario, then patient don't need IVIG, just aspirin alone is enough lah. So but the aspirin dose is still anti-inflammatory dose. So you give lah for 2 weeks, for example, then you review back patient after 2 weeks, take back the blood, see the CRP, see the inflammatory markers and all that. Is it coming down or not? If it's coming down, then you probably can change to antiplatelet dose lah. So there are 2 doses in Kawasaki, right? So one is anti-inflammatory dose, one is antiplatelet dose. So the dosage is very different, right? The anti-inflammatory dose is very very high, 30 to 50 mg per kilo per day. That is what stated in the fixed protocol. But I think in certain guideline, probably in the Japanese one, they probably use the higher, even higher than that, 80 to 100 mg per kilo per dose. So in the end, it all depend on the centers lah. Some center practice like this, some centers practice like this. Depends on whoever managing. But in the end, the aim is the same, to reduce the inflammation during the first 4 to 6 weeks too. Because Kawasaki is a ongoing inflammatory process, can last to up to 6 weeks. So that's why you review them. Once you review them, you see the inflammation has kind of like settling, then you can change to antiplatelet dose. So for example, patient come with Kawasaki during the first week, second week, you echo them day 5, day 6, day 7, no aneurysm, no dilated coronaries. Does not mean later on they will not have any aneurysm. As I said, the inflammatory process happen for the next 4 weeks, 6 weeks. So if the inflammation is still ongoing, so there is still chances for them to develop aneurysm later on. That's why you see back in 2 weeks time, you repeat the bloods, you repeat the echo. See if there is no aneurysm, then you probably are quite safe lah. But then you see back after 1 month with same thing as well. You scan back then again, ensure there is no aneurysm. Because if there is aneurysm, the treatment will be different already. You may need double antiplatelet, not just aspirin alone is not enough. If you see the patient have fever again after 2 weeks, still having some spike of fever, you may want to give second IVIG. Okay, because the inflammation still not fully resolved. So the question you ask whether some patient don't use aspirin, some patient don't use IVIG, not really accurate lah in terms of the questioning, but aspirin is very universal thing lah. Okay, but they may have add-on like clopidogrel, dipyridamole, all those antiplatelets lah. Okay. So aspirin is what group of drug?
Aspirin is the salicylic acid.
Yeah, salicylic acid. Salicylic acid and the what group of drug? What's a big umbrella group? Yes, it is an NSAIDs lah. NSAIDs have a lot of drugs group, right? So the common one is what? Other NSAIDs that you know about?
The common NSAIDs are there's a COX-1, COX-2.
Oh, you know the big shot straight away, the Celecoxib, the Celebrex and all that lah.
The normal ones like ibuprofen.
Yes, ibuprofen some more. Constant is what?
one is
methanoic acid. Okay, so I think Ponstan is basically the most common NSAIDs there is lah. For adult lah basically. We don't really use it like in children. Ibuprofen in children is probably the most commonly used NSAIDs. Okay, second most commonly used NSAID in children is aspirin lah, because of Kawasaki. And then we also have ibuprofen. Other than being antipyretics, we also used for anti-inflammatory in like Hinox Shangline Pupura lah, HSP, because of the joint pain and all that lah. We don't really use aspirin lah, because problem with if patient have influenza like illnesses, you give NSAIDs, what can happen? What complication can happen? What syndrome can happen? Can happen. Patient can have no SGS. It's to have to do with your altered mental status or encephalopathy. What kind of syndrome? Hello. Sorry?
Not really sure.
Sure what? Oh, what syndrome? Oh, Rey syndrome. Tak dengar? Reyes or Reyes. I don't know lah how to pronounce it. It's REYE syndrome. Rey syndrome lah. They can have altered mental status because of encephalopathy due to the aspirin lah. So kalau you bagi NSAID, patient high grade fever, cough very bad, runny nose very bad, sound very influenza like kan. So you don't give NSAIDs lah. Okay, because you can have Rey syndrome, one thing. Second problem, if you the practice outside in general practitioner, they give sub medication, suppository medication. You know your paracetamol got sub, certain medication got sub, but there is NSAID also come with sub. We call subboron or diclofenac sodium or diclofenac potassium lah. Then this NSAID, if you give boron in patient with influenza-like illness, they can have another problem associated with altered mental status lah, very bad brain inflammation called ANEC, acute necrotizing encephalopathy. So that's why we really reserve NSAID for very specific diagnosis lah, like Kawasaki and HSP. That's probably. Then sometimes patient allergic to paracetamol lah for antipyretics. Because the NSAID also have issue with the kidney. It's reduced the perfusion to the kidney as well. So in the long run, predispose patient to CKD. So that's why nephrologists don't like NSAID lah, especially in children lah. So these two or three kind group of patient we use the NSAIDs lah. So patient on aspirin long term. So sometimes we have to need to advise them lah. Patient unwell apa semua tu, be a bit very careful lah. Patient datang with high grade fever, sometimes they may have to like stop it for a short while till they recover because of that risk lah. But sometimes the benefit and the risk you have to weigh. The benefit of you starting aspirin to prevent what? No, you don't prevent aneurysm already. If happen, it happens. Okay. If already got dilated, it will remain dilated, but it will regress over time, but that tissue become fibrotic. So they have chances become stenosis also later on lah. But they also at risk for developing thrombosis lah, especially the aneurysm is still there. So the function is to thin the blood. Thin the blood, why? Why you want to thin the blood? Yeah, the main aim is thrombosis. So how you answer is also important. If you answer aspirin to prevent aneurysm, definitely it's wrong answer, because aspirin don't prevent aneurysm unless the aspirin is anti-inflammatory dose lah. That's why to reduce the inflammation. So by reducing inflammation, you reduce the risk of developing aneurysm. Okay. But IVIG is more effective lah to do it. Okay, so as the way the benefit to prevent thrombosis and to benefit of risking patient developing Rey syndrome in URTI symptoms lah. So the risk is still there, even though it's like 1%, 2%, but because the risk of developing MI is much higher, much risky complication. You got MI, you die straight away lah possible. You got brain, you probably still sampai juga you stop the medication, everything. It's not as bad as having MI. So sometimes you just have to risk it lah. So in the end, treatment wise, if benefit higher than the risk, you still do it lah. But we have to really explain to the patient lah. But if the risk is equal or higher, then the benefit is not good for the patient lah. So in the end, our first amendment, first all is what? Do no harm, kan? Sekali. So like this patient got aneurysm before. Yang Dr. Kui asking just now, got dilated left main coronary artery. Z score dia tak besar sangat lah, 2.6 only. It's very mild. It's a small aneurysm. Okay. But it's fine IVIG resistant given metapred juga semua lah. So now the one he mentioned just now, he want to do imaging. I corrected him lah because the MRI is more of coronary angiogram of coronary lah. So you want to do by CT scan, you will do the angiogram through the CT scan, see the size of your coronaries. So why we want to do it? Because echo cannot see the whole coronary. You only see the proximal part. So you don't know what happened to the medial. You don't know what happened to the distal. Okay. So the CTA coronary will examine the whole coronary itulah to look for any aneurysm or any stenosis. Okay. So if that one clear, sometimes you can discharge patients something like that. Okay. But this one got aneurysm lah. If patient got aneurysm, we just follow them up lah. Till like forever. Because once they develop aneurysm, even though the aneurysm has chances to regress, mean the coronary arteries from big become normal again, but the tissue is not the same anymore. Because what happened? Because that severe inflammation attacking your vessel layers. Guess what? How many layers is there? About 3, I think. Tunica media, Avencia, and all that. I can't remember exactly. So once this layer is damaged, so when you got your cut, everything, you've cut very big, it becomes scar. Same as well for the vessel. So that the remodeling is it's not a normal remodeling of vessel. It's a remodeling of fibrotic tissue. So that's why they can have chances to develop stenosis. Because once you remodel the fibrotic tissue, also may contracted, may become smaller. So there's the MI can happen because of stenotic part. That's another reason, or because of thrombosis. 2 possible reasons. Developing myocardial infarction. Okay. So even though they've been discharged, then we need to counsel the patient that even though the coronary normal already, no need to makan aspirin anymore, they still have chances of developing MI lah. Because the pathophysiology of Kawasaki is like that. MI in adult because of what? Atherosclerosis formation over time. That one also involving some inflammatory thing lah. Plus all cholesterol part lah. I also don't really remember the adult punya MI pathophysio lah. Okay, so something to do with atherosclerotic punya changes lah kan. Okay. So different pathophysio, but in the end product is still the same lah. Kalau you got MI, still the same presentation lah. But not to say that patient with Kawasaki disease with aneurysm cannot have atherosclerosis. They still can have. So but the adult cardio need to know lah patient have Kawasaki. So plus aneurysm some more. So the management is probably they need to look for the stenotic part on top of the atherosclerotic part as well. Okay, so in the end the intervention probably be the same lah, but the mechanism of developing MI could be from either those two lah, which is your atherosclerosis or because of the previous Kawasaki punya problem. Okay, and patient need to know, they need to inform to their adult doctor lah of this Kawasaki. That's the main thing lah. We advise patient when we discharge them lah. Those yang with perfectly mildly dilated but no aneurysm, with more that group we discharge lah. But those with aneurysm, even though dah normalized, we still keep them lah because we want to do certain tests later on. You can see here. Baca. So those with risk level 3 mean those with aneurysm risk level 3 and above lah. So with 3 and above they need extra screening. So what screening? You find the answer? Yeah, they need the stress test lah. We need to stress them, see lah whether any changes or not. But most of the time we just follow them up. If they remain asymptomatic, okay, I will still just follow them up lah. We usually reserve when they get bigger a bit lah, more than 12 years old, teenagers punya age lah, easier to do lah because they need to follow certain instruction. Even to do imaging pun they need to be at least 10 years old because they follow instruction better lah. And then another thing, the heart rate lah, because the heart rate to tachycardia is not good. We won't get nice imaging because we need the heart to pumping, you see the volume adequately or not lah, because when you pump too fast also imaging also tak bagus.